Welcome to the Explainer. Managing bipolar disorder is one of the biggest challenges we face in clinical practice. So in this Explainer, we're going to translate those complex guidelines into the practical, real-world counseling points and strategies that you can start using with your patients tomorrow. All right, let's dive right in. We'll kick things off with the diagnostic puzzle, which can be super tricky. Then we'll talk about your specific role on the care team. After that, we'll get into the nitty-gritty of managing acute mania and depression, and we'll wrap up with what is arguably the most critical piece, long-term maintenance and adherence. So let's start with one of the biggest hurdles, especially in a community pharmacy setting. How do we tell the difference between bipolar disorder and unipolar depression? Getting this right from the very beginning changes absolutely everything about treatment. Okay, picture this. A patient comes to you with all the classic signs of depression. They're exhausted, feeling hopeless, just have no energy. Our immediate thought is, of course, major depression. But the first question we should always ask ourselves is, what else could this be? And this number really drives home the scale of that diagnostic challenge. Up to a third of patients who walk in with what looks like depression might actually have bipolar disorder. That's a huge number. And it's exactly why your role in screening for a history of mania is so unbelievably critical for getting them on the right treatment path. Understanding this difference is key. It's everything. Mania is the big one. It's severe, lasts at least a week, can even involve psychosis. This is the defining feature of bipolar 1. Now, hypomania, that's a milder, shorter state of elevated energy, but without that severe impairment. And that's what's characteristic of bipolar 2. So the diagnosis really boils down to one simple question about the patient's history. Have they ever had a full-blown manic episode? If the answer is yes, boom, the diagnosis is bipolar I. If they've only had those hypomanic episodes along with their depression, then we're looking at bipolar 2. So where do you, the pharmacist, fit into all this? Well, your role on the patient's healthcare team is absolutely vital. You're not just dispensing pills, you are actively monitoring, managing, and educating. You're on the front lines. These right here are the fundamental goals we are all working toward as a team. And you'll notice, it's about way more than just mood. It's about getting those acute symptoms under control, preventing future episodes, helping that person get their life back, and managing any other health issues that are along for the ride. And this is where you really shine. A team approach is without a doubt the best way to go. And you are often the most accessible healthcare professional that patient sees. That puts you in the perfect position to provide ongoing education, monitor for side effects, and encourage the adherence that truly, truly improves outcomes. Okay, let's get into the specifics. We'll start with the first clinical scenario you might see. A patient in the middle of an acute manic episode. The name of the game here is immediate stabilization and safety. The absolute #1 priority is to de-escalate the situation safely. And the very first, most critical step from a medication standpoint, stop any antidepressant the patient might be on. It's like pouring gasoline on a fire. It can just fuel the mania. Here are our first-line tools. You've got the classics, lithium and dalvalprox, and your key role here is managing that therapeutic drug monitoring, so really pay attention to those target blood levels. The second-gen antipsychotics are also first line, and you'll often see them combined with a mood stabilizer, especially in severe cases, to get faster control. Your counseling here is just mission critical. For lithium, you have to teach the signs of toxicity, the tremor, ataxia, diarrhea. You've got to stress stable salt and fluid intake and warn them about interactions, especially with NSAIDs. For divalprox, you have to talk about weight gain and, crucially, its teratogenicity. With the antipsychotics, it's all about metabolic monitoring and sedation. And hey, don't forget the unique admin details. Like with asinapine, it's got to be sublingual with no food or drink for 10 minutes. Little things make a huge difference. All right, let's pivot and talk about the other pole of the illness. Now, bipolar depression is not the same as unipolar depression, and it requires a completely different treatment playbook. This is the single most important rule. You could almost call it the golden rule of treating bipolar depression. Using an antidepressant all by itself is not recommended. Why? Well, it can be ineffective, but even more dangerously, it can actually trigger a switch into mania or hypomania. Now look closely at these first-line options. Notice what's missing? Yeah, you don't see any traditional SSRIs on this list. Instead, the therapy is dominated by very specific second-generation antipsychotics, like lurazidone and quetiapine, along with the mood stabilizer lamotrigine. Your counseling here is so vital for making sure these meds actually work. For lurazidone, you have to emphasize that it needs to be taken with at least 350 calories. If it's not, it just won't be absorbed properly. For lamotrigine, explaining that start low, go slow titration schedule is essential to prevent that rare but serious risk of rash. You have to empower your patients to call you or their doctor if they see any skin changes. Okay, so once an acute episode is under control, the goal shifts. We're now in the most critical phase, maintenance. The focus is now 100% on preventing the next episode, and this is a lifelong journey for the patient. The stakes could not be higher. Look at that number. There's a 70% chance of relapse within just 1 year without medication. This is why maintenance therapy isn't optional. It's absolutely essential for any kind of long-term stability. This right here is a fantastic, empowering tool that you can teach your patients. It's called the relapse drill. You help them recognize their own personal early warning signs. Maybe it's sleeping less, or maybe it's getting more irritable. Then you work together to create a clear plan so that when those signs appear, they know exactly what to do. It can help stop a full-blown episode before it even starts. Maintenance is all about a continuous conversation. You always have to reinforce that not sticking with the meds is the single biggest risk for relapse. From a clinical side, remember that lithium levels are often targeted a bit lower in this phase. And finally, be aware of all the options, like long-acting injectable or aripiprazole, which can be a total game changer for adherence. So to wrap this all up, if you take away nothing else from this explainer, let it be these 3 points. 1. Always ask about the highs in patients with lows. 2. Antidepressant monotherapy is a no-go. And 3. Never underestimate your role. Your consistent counseling on adherence is probably the most important factor in long-term success. We've covered the tools, the strategies, the pearls. The final question is really for you. Armed with this knowledge, how are you going to apply it to empower the very next patient with bipolar disorder who walks through your pharmacy doors? Because that's where the real impact happens.